Hi, this is Kendrick with worldmedicalschool.org. Today we're going to talk about pediatric diabetes. We did an overview a while back on adult diabetes and focused a little bit more on type 2. So if you're more interested in that, take a look at that other video. But we have some special considerations here with children, and we're going to focus a little bit more on type 1 today. So type 1 diabetes is the most common diabetes in children, and it happens to about 2 to 3 out of 1,000 kids. I think these numbers are from the ages 3 to 15 or something like that. And we don't have great numbers on type 2 diabetes, but the most important information about that epidemiology is that it is increasing rapidly. This one study from Cincinnati said that the numbers increased from about 0.7 out of 100,000 to 7.2 out of 100,000, and this was between like 1982 and 1994. So in a 12-year range, we had over a tenfold increase, and those numbers are still climbing. So what causes diabetes? Well, it usually comes back to insulin. Diabetes is a problem of processing sugars and other processes associated with insulin. So if we have a problem with production of insulin or release of insulin or insulin action, then all those things can cause diabetes. Now there's a really long list of ways you can actually cause this dysfunction. The most common by far in children is type 1A, which is an autoimmune destruction of beta cells. Now the beta cells are among the islet cells in the pancreas that produce insulin. So if you destroy them, then they don't produce insulin anymore. This is a type 4 hypersensitivity, meaning that it is T cell mediated. But there are antibodies that circulate, like anti-beta cell antibodies or anti-insulin antibodies that you see. And those can be used as markers, but they are not the actual causes of destruction. So there is a genetic susceptibility. We talk about DR3 and DR4 as the genes that are associated with it. But type 1 is actually less genetically mediated than type 2 is. And congenital rubella also has an association with type 1 diabetes and certain toxins. There's a question mark there because this is still being researched. And then basically any other way that you might want to destroy pancreas cells are ways that you can cause diabetes. So cystic fibrosis is a cause of diabetes. You can have fat necrosis after trauma that causes diabetes, and really there is a long list of any way that you might want to damage a pancreas. It can cause diabetes. Some endocrine causes that are associated with it are like Addison's disease and others. So type 2 is characterized by either insulin insensitivity or beta cell dysfunction or both. So type 2 is usually associated with obesity, and so we're talking about having so much sugar available that the cells begin to become insensitive to insulin. And they talk about wearing out the beta cells. I don't know if that's actually the process, but it also is associated with beta cell dysfunction. You can also have a mixed cause where you have type 2 mixed in with type 1, which can get kind of complicated. And then you have this MODY, or mature onset diabetes of youth. And this is actually more common than type 2 diabetes is in children, but much less common than type 1. And it's caused by genetic defects, either in beta cell function or insulin receptors or other protein defects. So insulin is a signal. It tells the body that there's sugar around. So whenever we take in sugar, there's certain processes that should stop and certain processes that should start, because now we've got extra sugar on board, so we don't need to be producing sugar, and we don't need to be breaking down glycogen, and we don't need to be breaking down fats and proteins, because we've got an excess energy supply on hand. So insulin is the signal that tells the cells to stop these processes. And deficits in insulin just mess up that signal cascade. So we have extra sugar on board, but still we're making sugar, and we're still breaking down fatty acids and other things that we can use for energy. So all of the effects, the signs and symptoms that we're going to talk about in a second, and all the damage that's done by diabetes, think about why it's happening in terms of this excess of sugar that's on hand, and also the lack of signal telling the cells to stop these other processes. So a lot of these kids don't have any symptoms, or at least not noticeable symptoms. And especially in the early stages of type 1 diabetes, there's nothing to see, because the remaining pancreatic islet cells are sufficient to run the metabolic processes in the body. It's only when you get down to 20 or 10% left of your beta cells that you start to get real symptomatic, because then the sugar load cannot be compensated by the ability to produce insulin. So this is the point where you get polydipsia, because you are you've got so much sugar in the blood, you can't make enough insulin to get it transported into the cells, and your kidneys at this point get overloaded with sugar, and they can't pump the sugar back in. Basically, they can't filter the sugar back out of the urine, so you get a lot of this sugar in the urine that pulls water out with it, so you're losing extra water, so you need to drink more. So you get the polydipsia, the polyuria. The polyphagia is caused because we don't have a signal saying we have extra sugar on hand, so the body is still saying we need more sugar, so you're still eating. And you get weight loss because you're still breaking things down, you're not storing as you normally would if you have extra energy on board. So, and then these are the signs and symptoms that happen gradually. The acute symptoms that a lot of kids still present with are ketoacidosis, and in type 2 diabetes, HHS, which is hyperglycemic. Oh no, I can't remember what it stands for. Anyway, this HHS is a hyperosmolar hyperglycemic syndrome, maybe. Anyway, what it is a ketoacidosis-like process that happens more in type 2 diabetes. And hypoglycemia is only an acute presentation of treated diabetes, because it's now I'm really off. It is an effect of our insulin, exogenous insulin that we're giving. Okay, we're going to move on now. So diagnosis. We're going to use a history and physical to help us to know if we're going to test for diabetes. So if they have any of these symptoms in the office, then we get a blood sugar test, and it's usually pretty straightforward. The reason I've got a question mark here is because if it's so straightforward, then why do we still get all these kids presenting with ketoacidosis? Well, it goes back to that fact that we don't get problems until the pancreas just can't produce enough insulin anymore because it's down to 10 or 20% of its capacity, and there's a threshold where it's just not enough. So in asking around, I don't know if we have very many ideas about how we can catch these kids before they go into ketoacidosis. The good news, though, is that we've gotten quite a bit better at treating ketoacidosis, and the fatality rates have gone down from virtually 100% to much lower. So I saw a figure as low as 1%, but somebody told me 30%, so I'm not sure how good we are at preventing morbidity and mortality with ketoacidosis, but we've gotten a lot better, and we're still getting better at it. So the lab tests that we can do, we do have some tests that are helpful, or that we could use for screening, but they're just not helpful in type 1 because, first of all, you get false positives if we're talking about antibody tests that we can see that we have autoantibodies for beta cells. Then we can say, okay, this person is likely to develop diabetes, but there's a lot of people with autoantibodies that don't develop diabetes. So the screening is not helpful except for kids who are at risk for type 2 diabetes. And we'll talk about what those risk factors are in just a second. So the tests that we can do are fasting plasma glucose, which if you have above 126 2 times, then you're diabetic. A 2-hour post-challenge above 200. And in 2010, they also approved hemoglobin A1C as a diagnostic test. So distinguishing type can be a little bit tricky sometimes in your kids who are at risk for type 2 but presenting with type 1, and currently that's still kind of based on risk factors and autoantibodies, and it's a little bit of a clinical diagnosis. So the criteria for testing type 2 diabetes is if you're overweight and you have 2 of the following. So you either have a family history, you are pretty much any other race besides Caucasian, and you have one of these signs like acanthosis nigricans, hypertension, dyslipidemia, PCOS, or you had maternal gestational diabetes. So if you have 2 of those, then it's a good idea to test for type 2. So you start doing this at 10. If they don't have it, then you test them 3 years later, etc. The differential diagnosis, I left this slide blank because there's a pretty long list, and it depends on what symptoms we're talking about. If we're talking about the polydipsia, polyuria, then you can include diabetes insipidus, which is a malfunction of the pituitary gland or the ACTH pathway. The ADH pathway, antidiuretic hormone pathway. Or if we're talking about some of the other symptoms like the ketoacidosis, then any viral illness can look like ketoacidosis. So there's a long list, and just make sure that you keep a high index of suspicion for kids for type 1 diabetes. So ketoacidosis, why do we have ketones? I'm getting into a lot of pathophysiology here today, but I think it's pretty important. So the ketones are products of breakdown of fatty acids. So why would we have them? We don't normally have ketones circulating in our blood or in our urine unless we are fasting, because that means if we're fasting, then we need to be breaking down these fatty acids and producing usable forms of energy. So one of the things that can cause ketoacidosis is if you have increase of stress in the body, like by illness, or if you have a diagnosis of diabetes and you're being treated and you are not compliant, then you can also run into ketoacidosis. But basically, it's just a process caused by the breakdown of ketones to try and or the breakdown of fatty acids in order to make a usable energy source, especially for the brain. So the signs and symptoms, a lot of times these kids just feel sick. If you have a type 1 diabetic who feels sick, test their ketones, especially if they have any vomiting. If they have vomiting, then you really need to suspect ketoacidosis. And then if it gets worse, then they can get lethargic, they can get confused. All ketoacidotic kids are dehydrated, so you get all the signs of dehydration. Deep respiration is called Kussmaul breathing, is a later stage of ketoacidosis, and at some point you get an inability to stand. So all these things are reasons to get to the hospital. Now, you can't have ketones present in your urine or in your blood without being in ketoacidosis. And if that's the case, then you can just treat with insulin and monitor the ketone level. But if they begin to have any of these signs of acidosis, then you need to get into the hospital. And the main treatment is fluids. I put insulin first on accident here. Really, fluids is the first thing we need to get in, because you actually don't want to put in any insulin until we have corrected the dehydration. The reason that, or at least we've started correcting the dehydration. The reason that we don't want to do that is because if we decrease the blood sugar level too rapidly, then we can have, there's an osmotic process that causes brain damage. So make sure that we get fluids in, watch the electrolytes, and don't overtreat, so you don't want to cause hypoglycemia. So speaking of hypoglycemia, this is when you get less than 60 milligrams per deciliter of sugar. It's almost always caused by insulin, in diabetics anyway. You can get sweating, trembling, palpitations, headaches. So all these things are sympathetic signs, so that's the reason we talk about beta blockers being able to mask these symptoms. So you need to watch out with beta blockers in children who are also diabetic. The treatment of this is glucose, so you can use a soft drink or some cake frosting. You want to have those things on hand wherever people are. If it gets more serious, then you can do IM or subcutaneous glucagon. So the treatment of type 1 diabetes, the long-term treatment, the goal is to keep blood sugars close to normal, or what they normally would be if you had a functional pancreas. So you follow up every 3 months to keep an eye on blood sugar levels, the A1C levels. And the most important thing is to teach the patient and their parents about how to manage this disease. They basically need to be their own doctors in order to manage some of the complications of type 1 diabetes. So insulin treatment, once you start insulin treatment, you're going to be preserving some of the beta cell function that's still left. So you remember, you probably got 10% of your beta cells left at diagnosis. And once you bring the blood sugars down, then that beta cell function will return temporarily. So you get a honeymoon period where you are still producing endogenous insulin, and that may last months to a year. And so during that period, they're going to be using less insulin. But virtually all diabetics will lose all, or type 1 diabetics will lose all pancreatic function at some point. So this honeymoon period will end, and you're going to have to change your dose. Kids get 0.5 to 1 unit per kilogram per day. Adolescents a little bit more. We have these different types of regimens that we used, the split mixed and the basal bolus. And these are based on the different types of insulin. So the regular insulin that we have has a peak onset within like a half an hour. And this is the insulin that we make in our bodies. And we have some synthetic insulins that act a little bit faster than that we use. And then there's NPH, which I never can remember what NPH stands for. I know the last word is Hagedorn. Anyway, the normal protamine Hagedorn, something like that. Anyway, so that lasts 12 to 20 hours. It peaks at around 4 to 5 hours. And then you have these long-acting ones like detamir and glargine. Okay, so a mixed split or a split mixed is going to be when you give one of these short-acting ones like Aspart, Lispro, or glulisine along with NPH, and you give it 2 times a day, so before breakfast and before dinner. And so you get the fast-acting to cover your insulin needs right after this meal, and then you have a little bit longer acting with the NPH that will help you cover you later through the day. So the benefits of this is that you don't have to calculate anything. You just have your daily dose that you take every day. The drawbacks is that it doesn't match your normal insulin needs. So usually in the afternoon with this, you're going to need a snack because you got insulin, but you don't have food. So that can cause some hypoglycemia if you don't get a snack. And then as we get a little more confident in our patients' and parents' ability to manage the medications by themselves, then we might move to a basal bolus, which will include one of these long-acting like detamir or glargine that covers you throughout the day, and then you take one of these rapid-acting ones right before meals, and that will match pretty closely to what normal insulin would be. The only catch to this is you have to calculate how much of this rapid-acting insulin that you need before each meal. So you count your carbs and figure out how much insulin you're going to need to cover the meal or the snack. It's good because it is flexible. You can eat at different times, and you can choose what you're going to eat. But it is also more difficult because you have to calculate things, and so it can lead to confusion and missed doses and complications if patients aren't real good at managing this themselves. So diet, exercise, no smoking, constant monitoring and education are all the key principles in managing type 1 diabetes. Remember that snack if you're on the mixed split, the split mixed regimen. Make sure these kids can get treats because otherwise they will sneak them and get in trouble. And also watch out for eating disorders that are a little bit more common in type 1 diabetes. Major complications that we're worried about are often caused by damage to the vasculature. And the major theories about why this happens include the idea that all this extra sugar basically sticks to other proteins. So you get these glycosylated end products that build up in tissues, cause inflammation and damage to vasculature. So that can cause this retinopathy, the nephropathy, the neuropathy. All these things are major complications of diabetes. And in a similar process, you also get worsening of atherosclerosis, which leads to heart disease, peripheral vascular disease, and stroke. And remember that if you have one autoimmune disease, it's a good chance you'll have another as well. So the treatment of type 2 for kids is all about the lifestyle. We can use medications, but this is a preventable disease. And these kids need to change their lifestyle, and more importantly, these parents need to change what they're doing, and so the kids can get better. You can totally get better from type 2 diabetes in kids. So this is on the parents and on the patient to change their lifestyle. If we can't control it, then we can use metformin, we can use insulin, but the thiazolidines are not indicated, and I don't think sulfonylureas are either. So if you want to volunteer, I just thought of this new way that I think that would be really helpful to other students. So every time you watch one of these videos, please just write a quick question that would test other students on the content of the video. So if you just put that one question in the comments, for example, you could say, what types of insulin are involved in a split mixed treatment regime, and then leave your answer, your question and your answer in the comments, and then we'll compile all those later, and that will be a big help to, I think, to the other students who use this. If you want to get involved more, go to worldmedicalschool.org/volunteer. Thanks.